This child is suffering from dengue hemorrhagic fever. His capillaries are leaking fluid and he has a tendency to bleed. This is what distinguishes dengue hemorrhagic fever from dengue. It is a painful disease which can cause severe bleeding and, if not treated properly and timely, often results in death. But the problem of treating dengue hemorrhagic fever doesn't start here on the ward. It starts much earlier, wherever patients are first seen. All healthcare workers need to know how they might suspect a diagnosis of dengue and know how they and the parents can treat mild symptoms and be on the lookout for signs of dengue hemorrhagic fever, especially the signs signifying the need for admission and careful treatment. If you are in a dengue-affected area, you should suspect dengue fever if you recognize one or more of the following symptoms. Fever pattern: an abrupt onset, high fever, and sometimes a saddleback fever. A fever that does not completely respond to paracetamol syrup. Symptoms of headache, retroorbital pain, muscle pain, and joint pain. A child may appear physically tired or have other altered behavior, for example irritability or vomiting. The skin may show signs of a flushed face, or there may be erythema or a maculopapular rash on the head and trunk region of the body. If you suspect dengue, then the next step is to look for risk factors or features of dengue hemorrhagic fever. Increasing size and tenderness of the liver might also suggest dengue hemorrhagic fever. Distinguish the symptoms from other common illnesses such as measles or malaria. Laboratory tests compatible with dengue hemorrhagic fever are a decrease in white cell count, decrease in platelet count, and an increase in hematocrit. A blood film may also show atypical lymphocytes. A specific test for dengue hemorrhagic fever is the tourniquet test. This is done by first measuring the blood pressure. Remember to use a blood pressure cuff the right size for that child. Then inflate the cuff to a pressure exactly halfway between systolic and diastolic pressures. Now keep the pressure inflated for 5 minutes. After releasing the cuff, look carefully for small red or purple bleeding points in the skin, known as petechiae. These might be tiny, the size of a pinhead. If there are 10 or more bleeding points in 1 square inch area, then the test is positive. But remember, the tourniquet test can be negative, especially early in the disease, or in obese patients, or in patients with shock. So if there is any suspicion of dengue or dengue hemorrhagic fever, here is what to do, what not to do, the warning signs to look for, and when. What to do? Bring the temperature down. Whatever the cause of fever, a very high temperature is dangerous and can cause fits known as febrile convulsions. To bring down high fever to below 39 degrees centigrade, gently sponge the child with a cloth soaked in water and give paracetamol. Maintain hydration and electrolyte balance using oral fluids. Thirst is common, but many children need help to drink. Avoid giving only water, as this will not replace lost electrolytes. Continue breastfeeding if possible. Keep mosquitoes away, for example using nets, to stop spread of the disease from a person with dengue. Remember, unlike malaria, the mosquitoes that spread dengue will usually bite during the day. Avoid certain drugs, for example aspirin or non-steroidal anti-inflammatory drugs such as ibuprofen, which in this child led to bleeding. Avoid inappropriate intravenous fluids. Always use oral fluids if the child is able to drink. In dengue hemorrhagic fever, if intravenous fluids are given when not necessary or too quickly, the extra fluid can pour out of the leaky capillaries into the tissues. You may see this as puffiness around the eyes, or even abdominal distension due to fluid in the peritoneal cavity. But most importantly, fluid easily leaks into the pleural space, causing pleural effusions. And by pressing on the lungs, this makes breathing difficult. Here is a chest X-ray of a child with pleural effusions. Because the child was lying down when the X-ray was taken, most of the fluid just shows up as a diffuse hazy shadowing behind the lungs. But the arrows show where the fluid is also pressing on the sides of the lung. The wrong kind of fluid, for example too much 5% dextrose on its own, without any balanced salt solution, can also cause problems, such as convulsions due to brain edema or swelling. The warning signs of what to look for and when. Parents as well as healthcare workers need to know these, as most of them signify that the child needs admission to hospital. It's important to remember that the risk period is especially high in the first 1 to 2 days after the fever subsides. This is known as the critical period. The warning signs include refusing to accept oral fluids or vomiting, a sleepy or restless child, bleeding, especially gastrointestinal bleeding, with fresh or old blood in the vomit or stool. Old blood in the vomit looks like coffee grounds. In the stool, it may resemble thick black coal tar. A child suffering from abdominal pain. Skin mottling, cold sweaty skin, or cold hands and feet.
Overall, you see that very well from the top end.
Absence of urine in the last 6 hours. In addition to the above, doctors or nurses should also measure capillary refill time, heart rate, respiratory rate, blood pressure. Of all these, a capillary refill time of more than 2 seconds, as shown here, is especially easy to detect. If all the points we just talked about are absent, the child may be sent home with careful advice to parents to remember what to do, what not to do, the warning signs to look for, and when. If there are any concerns or if the parents are unable to comply with these instructions, then consider admitting the child. Early signs of shock or significant bleeding need urgent referral to hospital. In dengue hemorrhagic fever, although a child may appear to initially survive a period of prolonged shock, hemorrhage will often become severe and other complications such as renal failure can develop that may also be difficult to reverse. A paediatric ward provides frequent and skilled observation and immediate expert management of these complications. Remember that the risk period is especially high during the first 1 to 2 days after the fever subsides. This is known as the critical period. It is during this phase that capillary leak can begin. Plasma leakage is the most important feature of dengue hemorrhagic fever and often precedes bleeding. This is a feature that needs special monitoring. A centrifuge and capillary blood tubes provide the most essential and frequently performed test with immediate results. As the capillaries start to leak plasma, the remaining red cells become more concentrated. Dengue hemorrhagic fever frequently shows a rise in hematocrit of 20%. That would be a change in hematocrit, for example, from 35% to 42%. Here is a visual demonstration of what happens when the hematocrit changes. As the plasma level falls, the hematocrit rises sharply as there is not enough fluid in proportion to the red cells. Remember, if intravenous fluids are given when not necessary or too quickly, the extra fluid can pour out of the leaky capillaries into the tissues. You may see this as puffiness around the eyes or even abdominal distension due to fluid in the peritoneal cavity. But most importantly, fluid easily leaks into the pleural space, causing pleural effusions, and by pressing on the lungs, this makes breathing more difficult. During the capillary leak phase, just enough fluid must be given to prevent circulatory shock. The paediatricians will refer to published guidelines or wall charts to give exactly the right amount of fluid at this critical stage. A falling hematocrit could be a sign of bleeding. This is an important sign where bleeding is concealed. Sometimes bleeding into the gut may not be apparent, for example, until it passes out in the stool or vomit. Remember, this sort of bleeding can be associated with severe abdominal pain. In children who are obviously recovering, fluid that leaked into the tissues, peritoneum, or chest cavity will be reabsorbed and may also result in a fall in hematocrit. Remember, nurses will still be observing children closely for any of the important signs. A child refusing to accept oral fluids or vomiting, sleepy or restless, a child suffering from abdominal pain, skin mottling, cold sweaty skin, cold hands or feet, a reduced urine output. These are all signs of shock which may require immediate increase in intravenous fluid. Bleeding, which may be visible or concealed, may require urgent blood transfusion if severe. A child whose breathing is fast or requiring more effort may require oxygen therapy and immediate reduction in the intravenous fluids. In addition to these observations, doctors or nurses will also monitor capillary refill time, heart rate, respiratory rate, and blood pressure. In critically ill children, these observations might be necessary every half hour. Features common in the recovery period which may support the clinical diagnosis of dengue hemorrhagic fever are a widespread itching rash, often with white centres, a slowing of the heart rate, but for definitive diagnosis, blood samples should be taken. Reporting of all cases must also occur to ensure appropriate public health measures can be started. Any deaths from dengue hemorrhagic fever should be examined closely. They often reveal the need for more resources or training. With constant evaluation and feedback to all involved, from community to specialist hospitals, more children with dengue hemorrhagic fever can be successfully treated and sent home.